Hi everyone, good morning. Welcome to the Charles Bonnet Syndrome Patient Information event. To introduce myself, I'm Helen Khan and I'm representing the NIHR Moorfields Biomedical Research Centre. I'm so proud today to be supporting this much needed event and I've really been overwhelmed by the emails that I've received in the run up to today. It's just been unbelievable. Also, the sheer volume of interest has really proven that this event is so hugely needed, not only for patients, but also for professionals who are seeing symptoms of CBS more and more as the stigma and fear is removed as more information becomes available for everybody. So that leads me on to take this opportunity to just say what a wonderful job Judith has been doing over the last 5 years since she set up her charity Esme's Umbrella. As many of you will already know, she's been working tirelessly to raise awareness and find help and support for those with the condition. And as the numbers today show, she's done a very, very good job at it. So thank you, Judith. Can I also say a quick thank you to Gareth and Sam from Higher Frequencies who stepped in today to help with the technical side, bearing in mind there are so many of you here today. Also a quick bit of housekeeping. You are all on mute and off video. The Q&A function is on the right-hand side of your screen. And there's also a little like icon. So if you like any of the questions, you can tick it and then those questions will rise up to the top of the page. We will moderate the questions as we go and we'll ask them at the end of the session or as many as we can. If your question is not asked today, we'll send questions to speakers afterwards and try and answer as many as we possibly can. And thank you very much and I'll hand over to Judith now.
Thank you so much, Helen, and hello and a very warm welcome. I have to say I am somewhat overwhelmed at the number of people who've registered to be with us today, but it is a mark of how Charles Bonnet syndrome has emerged from the shadows. It's now being recognised and destigmatised. I have a huge thank you to make to the NIHR Biomedical Research Centre at Moorfields and particularly to Helen Khan for hosting today's event, and to Thayer Pharmaceuticals, and to all of them for their unstinting support of Esme's Umbrella, which is still only me. On this day, 5 years ago, I launched Esme's Umbrella and the first Charles Bonnet Syndrome Awareness Day at the House of Commons. My aims were, and still are, to raise awareness of CBS, to find ways to support people who develop the condition and their families, and to source funding for research. I think I've made a start. My first project was funded by Fight for Sight, Thomas Pocklington Trust, and the National Eye Research Centre at Newcastle University. Others have followed, and there are more to come, one of which will be at Oxford University, funded by blind veterans, the Royal Society, the NIHR, the College of Optometrists, and I am very proud to say, Esme's Umbrella from my restricted fund held for me by Fight for Sight. I am very grateful to our speakers for agreeing to join us today and for their constant support. They are Dr. Dominic Fitch, Dr. Kat De Silva Morgan, Professor Maria Musaji, Keith Valentine, who represents the CBS community, and Dr. Jane McNaughton. While treatment and a cure is being researched, we need to create ways to care for people living with CBS. Before COVID-19, I had encouraged charities to set up Esme Room support groups at which people could exchange experiences and coping strategies. Discovering that you're not alone goes a long way to alleviate the stress of the vivid, silent, visual hallucinations. Not only did COVID-19 mean an end to those groups, but the isolation and stress caused by the lockdown exacerbated episodes of CBS. Louise Gao, who is the specialist lead for the eye health team at the RNIB, which now answers my helpline, told me that they were receiving double the number of calls, and worryingly, that people were reporting the images seen were much more frightening. This concurred with Retina UK's CBS buddies who work closely with Esme's umbrella and my overflowing inbox and Facebook page. As I was pondering what I could do to help, I was contacted by Mike Bailey at Christopher Grange and Bradbury Fields in Liverpool. He had previously been running an Esme Room support group, and he told me that his members were not only having similar experiences, but were missing the friendships made. He had an idea to replace the face-to-face group with a telephone support service, a chat service called Esme's Friends. This we did, and it has been a great success. We now have over 20 sight loss charities in the UK taking part, plus Fighting Blindness in Ireland. And in the USA, there are now 2 similar chat services. The first is hosted by Gary Cusick, who is a psychologist working exclusively with the visually impaired. It would be excellent to reprise that role here. He also takes all my American and Canadian inquiries. The second is an online CBS caregivers support group run by Diane Thompson, who is an occupational therapist. Caregivers are too often forgotten, but they need support too. For some people, more than a chat is needed, and the Macular Society now runs a specific CBS telephone group counselling service, to which I have referred many people this year. Amazingly, there is no waiting list for the counsellors. Not everyone dislikes what they see, but the frequency of the CBS episodes negatively affects quality of life. 2 quotes stay in my mind. One from someone who said to me, "It's like watching a gardening documentary, but I can't switch it off." And another who said, "It's like watching a horror movie that I would never have chosen to watch, and I cannot switch it off." After talking to people who could not cope with the nature of what they were seeing and were harboring suicidal thoughts, I contacted both the Samaritans and Silverline, neither of which was aware of CBS. They are now. This year, Esme's Umbrella was invited to join the DCMS's Tackling Loneliness network. The loneliness felt by people with CBS is not about living alone, although many people with CBS do live on their own. It's about being isolated in a world of uninvited images. Imagine how more isolated someone would be who had not received a warning about CBS. My plea to all ophthalmologists, optometrists, and orthoptists is to explain to their patients with diminishing sight what might happen. It might not, but forewarned is forearmed. I understand their concern that patients will be frightened at the prospect of CBS, but I can assure you the outcome for the person is much better if they recognize the first hallucination for what it is and don't think that they have developed a mental health condition. I know this because my mother, Esme, received no warning, and she had probably lived with CBS for many months before she confided in me. Her distress was palpable. But that was in 2009, and what Esme experienced then should not be happening now. However, feedback from Esme's friends tells me that for too many people, there is still no warning. Or when the issue of hallucinations is raised, the clinician is dismissive, yet it just needs one moment to listen and then to imagine what it is like to live in a world where you have little sight but are beset by hallucinations. And CBS can bring with it other problems. Not being able to distinguish between what is real and what is not prevents people from leaving home. Instinctively moving to avoid the sudden appearance of a tiger, rushing water, or flames causes falls, which may lead to a GP or hospital visit. We know that far too few hospital doctors and GPs are aware of CBS. So should the person confide the reason for the fall, and ushering down the mental health route will follow, which not only wastes precious NHS resources, but is more distressing for the person. Thanks to funding from Thomas Pocklington Trust, PhD student Catherine Fisher at Manchester University will be looking at falls prevention in CBS. The GPs and hospital doctors are on my list for 2021. I'm sure Dr. Amit Patel's name will be familiar to you, but if not, I suspect you all know his guide dog, Kika, from her Twitter account. Amit does wonderful work in raising awareness of CBS, and it became clear that Kika was warning Amit before a CBS episode. This was intriguing, and I approached Dr. Claire Guest, who leads the Medical Detection Dogs charity, to see whether or not she thought this was possible. Indeed, she did, and an exploratory project is about to begin. Just as they did for COVID-19 detection training, the charity is asking for scent samples from volunteers, which will be small pieces of cloth and pop socks. If you live with CBS and are willing to help, please contact me. Details will then be sent to you. Gail Barrow, who will run the project, stressed this does not form part of any formal trial and is purely a dog training investigation at this stage. But I'm keeping my fingers crossed it will continue to be full-blown research. In a moment, I will hand you over to Dr. Dominic Fitch, who, as I'm sure you know, is the sole globally acknowledged expert and first researcher in CBS and has been announced as the world's #1 for visual hallucinations of all types. Dr. Fitch is my medical advisor and is wonderful at guiding me down a realistic path when my non-medical background tries to lead me astray. I would like to say a very special thank you to him. Lastly, in case you haven't heard, CBS now has its own coding in ICD-11. I could not have changed the World Health Organization's mind on my own, and am indebted to Professor Andrew Dick here in the UK and Dr. August Kohlenbrander in the USA. Now, we need CBS to be included in specialist ophthalmology services through NHS commissioning. Oh, and we need many clones of Dr. Fitch. Unbelievably, it is 300 years since the birth of Charles Bonnet. But at last, the voice of the Charles Bonnet syndrome community is no longer a whisper. Thank you so much for listening to me. And I am now going to hand you over to Dr. Fitch, who will talk about past, present, and future CBS. Thank you, Dominic.
Well, thank you, Judith, and good morning, everyone. I was thinking back, I'm sure this is a historical event in the sense that I don't think we've ever had a whole workshop, a whole session developed to Charles Bonnet syndrome on this scale. So that's a fantastic achievement for Esme's umbrella. Now, I realize that I'm speaking to a rather diverse audience, and there'll be people with us today who've seen all this before. There'll be people, I hope, whom this is somewhat new for. And I'm also aware that there are many of you that won't necessarily be able to see the screens in front of you. And normally in a talk like this, I don't usually present slides, but the facilities of Zoom and these computer things, it's so tempting for me. I really wanted to show my favorite Charles Bonnet syndrome slides. So I am going to show slides, but rest assured, if you can't see the screen, you won't be disadvantaged in any way, because I'm going to try my very best to describe everything for you. So please don't strain your eyes to try and look at the screen. So as Judith has said, my task today is to talk about the past, present and future of Charles Bonnet syndrome research. And of course, we have to start with the man himself. And for those of you who can see, I've got 3 portraits of him in different times of his life. In fact, the key portrait that we would really need is the one when he's very young, as a child, because he starts off as something of a childhood prodigy, actually. He's by the age of 16, corresponding all around Europe on scientific discoveries of insects and photosynthesis and botany. And it's only when he reaches his 30s that he's no longer able to use a microscope, and he changes to a different type of research. He changes to philosophy and psychology. Now, I have on the screen now the front cover of a slightly later edition of the key work that we're talking about. And it's in French, the analytical essay on the faculties of the soul in direct translation. So this is from 1760, the original edition. Now, of course, today when you read it, it's more about the brain and how the brain works. And in it, it's a 2-volume essay, actually. In it, there are these 2 critical pages that starts the whole Charles Bonnet story for us. Now, again, I don't want you to struggle to read this. It's in French anyway, but I'm just going to paraphrase the section over here. So Bonnet says, "I'd like to say that I know a respectable man, full of health, candor, judgment, and memory, who, when fully awake and independently of every impressions of things around him, sees from time to time in front of him figures of men, women, birds, voiture." So voiture, this is 1760, means carriages, not cars, and buildings. And then if we look down here, he also talks about seeing brickwork, exterior construction of buildings, and he's talking about up here scaffolding and patterns and things. Now, there's an important bit down here where he says 2 important things. One, that the man is very old, and the other is that he had a cataract operation in both eyes that had originally been a great success. So the story is actually anonymized at this point, but we later find out in a footnote that this is his grandfather. This is Bonnet's grandfather, a magistrate in Geneva called Charles Lulin. And it's this description of visual impairment and visual hallucinations that we today call the Charles Bonnet syndrome. But I just want to highlight another factor here, that Bonnet emphasizes how old he is. And we're going to come back to that later when we talk about what we mean by Charles Bonnet syndrome. So here's the top 10 Charles Bonnet syndrome hallucinations that you get in ophthalmology clinics all around the world today. So the top one, and I've got an illustration here for those of you who can see it from a person with Charles Bonnet syndrome. Top one is simple hallucinations, as I call them. So little colored blobs, lines, shapes, and so forth. And then closely followed by these brickwork pattern or specific geometrical patterns. And it's often a lattice work, or sometimes it's described as chain link fencing. Then we have faces that loom up in front of you, and the faces are often distorted in some way. So the features may be very large, it might be prominent eyes or prominent teeth, and it's described as a gargoyle or grotesque in some way. And then we have the famous figures. They're often in costume, wearing funny hats. They can be small, so they're described as Lilliputian or children. And then we have text or letter strings. So these are little, they look like words, but if you try to read them, you can't see what it says. We've got snowstorms, or sometimes it's described as hundreds and thousands, the sort of sprinklings on cupcakes. And even today, it's not carriages anymore, but we still get some form of vehicle. So that's often a car or a bus or a lorry of some sort. So how common is this? We know that if you can see only to about a third of the way down the eye chart when you visit your ophthalmologist or high street optician. If you can only see a third of the way down, you have probably a 10 to 20% chance of having Charles Bonnet syndrome. And if you can't even see the top letter, that goes up to about 50 or 60% chance of experiencing Charles Bonnet syndrome. And if we look at one eye disease, that's age-related macular degeneration, that translates to between 70,000 and 420,000 people with Charles Bonnet syndrome in the UK. But if you add together all the other eye diseases, so that's cataract, glaucoma, diabetic retinopathy, retinitis pigmentosa, all the rarer ones, if you add everything together, these numbers are much, much bigger than that. So I have on the screen here the typical time course of Charles Bonnet syndrome, starting with a period of visual loss. It doesn't have to be sudden visual loss. It could be a gradual decline in vision. And then you start having your visual hallucinations, and they're typically very severe for the first few months. So they're there all the time, or they're occurring very frequently and very vivid. And then they gradually settle down over time. And we used to say everyone would be better by 18 months, a year and a half. But of course, we now know that is not the case because we did a large survey of people with Charles Bonnet syndrome a few years ago. And for those of you who can see the graph, I'm showing it here. And basically, we can say that about 75% of people have it for at least 5 years. And many are going on for much longer than that. Now, that's not to say that it retains the same intensity for all this time. So by 2 or 3 years, you would hope that the hallucinations are less frequent and you may only be getting them occasionally. But it's certainly not true to say, I'm afraid, that your hallucinations will go away within 2 years. Now, I've got on the screen now a pie chart of the different sort of emotional responses that you get to Charles Bonnet syndrome. And the biggest piece of the pie is this 2/3 of people that once they know it's absolutely normal, that's a normal consequence of visual loss, then the Charles Bonnet syndrome isn't really a problem for them. They don't really mind it. There's 10%, a small chunk of the pie, who positively enjoy it. And we've got about a 1/3 of the pie shown in red here, if you can see it. Those are the people that find it very distressing, that find it unpleasant, they're disturbing, they want it to go away, they're seeking further help. And these are the people that would mainly be knocking on Judith's door in Esme's umbrella. They're the ones that need help. And it's for them that we can think of Charles Bonnet syndrome as sort of crossing over from a normal response of the brain into a clinical problem. And they're the ones that we need to do something about. So what causes Charles Bonnet syndrome? Well, I've got a picture here of the man who came up with the theory 50 years ago, David Cogan, an ophthalmologist in Boston. And on the left-hand side, I've got a picture of the brain looked at from the underneath, and I've got the eyeballs at the top here. And the idea is that it's loss of signals coming from the eyeballs along the visual pathways, electrical signals that usually come from the eye. It's loss of these that causes changes in the back of the brain, the visual cortex. And these changes result in spontaneous firing of the brain cells that we normally use for vision when it shouldn't be happening. And also, if you like, a hypersensitivity to the remaining input that's coming in from the eye. So these are the two changes that we talk about. Now, I've used terms here that are very scientific and physiological, but you can also describe exactly the same thing in the same way as we think about a phantom limb. So phantom limb, for those of you that know about these, if you have an amputation, you can still feel your limb there. And you can think of Charles Bonnet syndrome in the same way as phantom vision. And similarly, the idea of filling in, that the brain is working hard to process vision. And when no signals come from the eye, the brain sort of fills in the gaps. So these are all absolutely correct. They're just different ways of saying the same thing. But technically today we call the theory release theory or deafferentation theory. So we looked to find evidence. It was basically just a theory until about 20 years ago, where we looked to find evidence for it using brain scanning. And we had people with Charles Bonnet syndrome in the scanner who just indicated when they had a hallucination. And for those of you that can see the brain slice on the left of the image, these are the eyeballs at the top here. This is the back of the brain at the back. And the red splodges are the bits of the brain that lit up when this person saw faces and colors. And it turned out that these bits of the brain were in the area that we normally use to process faces and the bit that we normally use to process colors. And so it came up with the idea that what you hallucinate depends on where in the brain these spontaneous cells are firing off. And if it's in the face area, you'll see a face. And if it's in the color area, you'll see a color. If it's in the object area, you'll see an object, and so forth. So let's wind the clock forward to the present day. What are the new things that I can tell you about this year in terms of Charles Bonnet syndrome research? Well, one of the things that Judith has already alluded to is the way we define Charles Bonnet syndrome. So now, if you can see the screen, I've got in the center here, the man that came up with the term. He's called Georges de Mauzière. He's in Geneva as well. And so he knows the Bonnet story, and he's a psychiatrist and neurologist. So he wanted to celebrate Bonnet's story with the Charles Bonnet syndrome. But unfortunately, he had a very strong belief that it wasn't to do with the eye. And I'll explain later why he thought that. And it's not just he didn't get it right. He had a strong reason for thinking that it might not be the eye. But anyway, so he wanted to celebrate a different aspect of the story. And if you remember that I said there was this thing that Lulin himself, Charles Bonnet's grandfather, had been old. So for de Mauzière, in the original definition of Charles Bonnet syndrome, it was about visual hallucinations in the elderly with intact cognition. In other words, they didn't have dementia. So it was elderly people without dementia who had visual hallucinations. Now, why is this important? It's important because, as we'll be hearing later from Professor Mukherjee, if you use this type of definition, you can't have Charles Bonnet syndrome in children. It's a different thing. And it's only because this year, or in the last few years, we've kind of had an official definition of Charles Bonnet syndrome that resolves this ambiguity, because ever since the 1930s, when Charles Bonnet syndrome was first described, there's been an ambiguity. Is it the eye? Is it not the eye? We now can say for sure that the way we should use Charles Bonnet syndrome is to include the eye. And I've got here the page from this classification of diseases that Judith has already mentioned, ICD-11. The number, if you need to know, is 9D56, and it's visual release hallucinations, also described as Charles Bonnet syndrome. So it's officially there, resolves the ambiguity. We can now talk about Charles Bonnet syndrome in the way that we've all been using it for the last few years anyway. And this will really help drive research forward and develop services for Charles Bonnet syndrome. So I think it's a very important development. There's no I think we mentioned this last year as well. There's no kind of official date when ICD-11 comes into play, but it's out there now. And I think all services are trying to align themselves with it. So it is an important time for us. So the other big development this year is all about treatment. And we've been saying for many years that, oh, well, Charles Bonnet syndrome is entirely normal. It's going to get better over 18 months. So we don't need to do anything about it. And I think a very important thing this year is that the message must change now. The message is that there is lots of treatment. There is treatment for Charles Bonnet syndrome, and there are lots of things that can be done about it. It's just that not everyone needs the full kind of set of things that need to be done. And I'm going to show you what these new treatment guidelines are in a moment. So a very important shift in what we tell people. So this is what I've been doing over the last 10 years or so, working on treatment guidelines for visual hallucinations in general. So this is the study funded by the NHS called SHAPED, and that stands for Study of Hallucinations in Parkinson's disease, eye disease, and dementia. And the main part of this study was to come up with guidelines across all of these conditions. And they've come out this year. Here they are. They're published. If you can see this, this is the paper. It's got experts from eye disease, from Parkinson's disease and dementia. We were all locked in a room in Newcastle. We weren't allowed out until we'd all agreed on what these guidelines should look like. And I've got them here to show you. Now, it's a very complicated flow diagram. I'm going to go through it slowly, bit by bit, for the important bits. But the important thing for these flow or these guidelines is they're for everyone. It's not just doctors that need to know this. It's all the allied eye care professionals. It's patients themselves and their carers. It's everyone needs to know about this, so that you all understand the steps that people should be going through, and the sort of the things that can be done if the previous step hasn't worked. So we start at the top of the page here, for those of you that can see this. I'm just going to have a sip of water, excuse me. We start at the top of the page, and as Judith has mentioned already, treatment for Charles Bonnet syndrome starts before even you've had your first hallucination. So this is all about forewarning and preemptive questioning. So every time you go to the clinic, it's the healthcare professionals that should be asking you about hallucinations, because we know that many of you, even now, are still too ashamed to mention them to people for fear of what it might mean. So you need to be told when you develop your sight-threatening eye condition that the possibility that you might have this. That doesn't mean to say that you need the full set of details, but you need to be aware of it so that when it happens, if it happens, you're sort of prepared for it. So we then move forward the clock, your hallucinations start, and then there's a set of things that everyone needs to have. And I'm going to go through these in a slightly more detail with specific reference to the people with eye problems. So everyone should have, or at least someone needs to think about on your behalf, your general physical state. Are there sort of infections or things? Your general cognitive state, I'll come back to that later on, and your visual health. So that means make sure you've got optimal refraction, so the best set of glasses for reading and distance vision that you can have. For those of you that need it, low vision aids can stop Charles Bonnet syndrome. And treatments for your eye condition. Of course, not all eye conditions have a treatment, but if there is one, making your eye condition, improving it or better, that will stop your Charles Bonnet syndrome. So that's obviously a very important thing to think of. The next step that everyone should get is medication review. And someone needs to think about, are you taking a culprit medication? And I've got a list of them here. They typically are medications for incontinence, urinary incontinence. Some people who are on atropine eye drops, that can make Charles Bonnet syndrome worse. Old-fashioned antidepressants and gastric, certain type, not all, but certain types of gastric ulcer medication. So if you're on one of these, someone needs to think, it could be a GP, it could be a specialist, someone needs to think, well, might it be better to take you off this medication, swap it for something else that isn't a culprit, and see if that improves your Charles Bonnet syndrome. And then finally, the last thing for everybody is what we've called person-centered therapy, which means that it really has to be tailored a little bit to you, what you know, who you are, and all those sort of things. And this is where all the information leaflets come in. Esme's Umbrella has one, RNIB, Macular Society have one, even the NHS has one. There are lots of these available. You need to have access to that. You need to have access to the support groups. So whether that's an Esme's Room or one of the Macular Society support groups. And you need to be taught how to stop a hallucination when it occurs. So there are all these little tricks that people can use to stop hallucinations at the time. That doesn't cure the Charles Bonnet, but it gives you some control over it. And this is things like the eye movement exercises, changing the lighting, general alerting strategies. So everyone needs to know this. So I've told you the three things that everyone needs to have. And for many people, that may well be enough. It may be that you don't need any more help with your Charles Bonnet syndrome. But of course, we know, and I've told you, and Judith is well aware, that there are many, many people for whom this isn't enough. And you need to go on to the next step then of things to do when the hallucinations become distressing, or if they are unpleasant, or you need further help. So there's a whole set of things that could be done next. And one of them is psychological talking therapies. And that involves the counselling and the Macular Society things. And there are new sort of talking therapies in the pipeline. So that may be something for the future. But at the moment, we're really talking about different types of medication for Charles Bonnet syndrome. And there are medications out there. So these have not been subject to a full clinical trial, but there's lots of case report literature and evidence. So these are not sort of random medications. These we know work, but it's often a question of finding the right one for you. So these are anti-epilepsy drugs, drugs for dementia, even though that doesn't mean to say you've got dementia, but these drugs work on a particular brain chemical that also acts on the visual system. So as a sort of side effect of this drug, it helps Charles Bonnet syndrome. And similarly for certain newer types of antidepressants, they work on a brain chemical that's also used in vision that can help. And then there's brain stimulation with electricity or with magnetism. Now, Kat is going to be talking about that in the next talk, so I'm not going to say much more about that here. Okay, so take home the message that there are lots of things that can be done for you, and the main thing today is that there are treatments for Charles Bonnet syndrome, but there's more coming in the future as well. And this is the last part of my talk now, looking ahead at what's around the corner. So as Judith already mentioned, she's not Esme's Umbrella is not a charity in itself. It doesn't fund research, but it is important in kind of lobbying all the charities to support Charles Bonnet syndrome, and certainly most of the research in the world at the moment, I suppose, is linked in some way to Esme's Umbrella. So that's an important thing. And it also has a role in oversight and coordinating these different research streams. So most of the current research is focused on this very simple question. If you've got moderate visual loss, you've got a 20% chance of having Charles Bonnet syndrome. So what about the 80% remaining? Or if you've got severe visual loss, what about the 40% remaining? Why don't they get Charles Bonnet syndrome? And this, of course, is the problem that de Morsier had when he was first defining Charles Bonnet syndrome, because he reasoned that, well, if 80% of people with eye disease don't get Charles Bonnet syndrome, how can eye disease be the cause? So we now know a little bit more about this. We know that if you have Charles Bonnet syndrome, you have this sort of hypersensitivity, this increased excitation in your visual cortex. Now, if you can see the slide at the moment, there's a brain slice of someone with Charles Bonnet syndrome, and the bit in red is the activation in their visual cortex. And if you compare that to someone that doesn't have Charles Bonnet syndrome, the red bit is much smaller, so they don't have this increase in activity. So we know that even though eye disease is the cause, it's doing something in some people with eye disease that it isn't doing in others. Now, I should say that the story is likely to be more complicated than this, because Kat is going to show you in a minute how we need to understand a little bit more what causes this hyperexcitability. But all the current research at the moment is in trying to work out what it is in the brain that's causing this difference between the lots of excitability in some people and the not very much or no excitability in others, even though they've got exactly the same eye disease. There's nothing different in their eyes. It must be something to do with their brains. So first set of Esme's Umbrella research, I think our original Esme's Umbrella fellow was Greg Elder up in Newcastle, and then he moved on and Kat has taken over. And so she's going to be talking about the Newcastle side of the study in the next talk. So I'm not going to say anything more about that. Judith's already mentioned the University of Oxford. So this is Professor Holly Bridges' group with Jasleen Jolly, and I think it's Bettina Ip. I hope I pronounced that correctly. Apologies if I haven't. So what they're looking at is brain connections and how this might influence Charles Bonnet syndrome. So for those of you that can see the screen, I've got one of the techniques they're using here. It's resting state connectivity. So subjects lie in the scanner at resting, and it's basically looking at how different bits of the brain communicate with one another. And if you can see that the pictures, you get these lines between different areas showing the strength of talking between different areas. And so what they're looking at specifically is whether it's connections from outside the visual cortex that are sort of feeding information and causing this hyperexcitability in Charles Bonnet syndrome. And they've got another technique called diffusion tensor imaging, which is it can actually look at brain pathways in brain scans. And if you can see the image, it's these kind of lines, these pathways that we're able to dissect out in brain images to show connections between areas. And again, this is another way of looking at excitability and where the connections from outside the visual cortex are causing visual cortical excitability. And finally, they have a sort of version of a mass spectrometer. They're able to look at chemical concentrations within the brain, particularly GABA, which is a sort of inhibitory chemical, and glutamate, which is an excitatory chemical. And they're able to see whether there are differences in these concentrations in people with Charles Bonnet syndrome. Now, I should say that Kat's already done this in Newcastle, and she'll be showing you some preliminary results from that. So the Oxford group will be either adding to this information or doing it in a slightly different way to sort of build on what we already know. Next group is in Cardiff. So this is Matt Dunn and Christoph Teufel. So these are looking at Charles Bonnet syndrome from a slightly different perspective. So they think of hallucinations as a mismatch between expectations of what you think is going to happen in the world and the information coming into the visual system. And they've got a very fancy way of measuring hallucinations. So for those of you that can see the screen, they have a sort of a stimulus made of moving dots that moves on the screen, and your eyes can't help but track that movement. So it's the same thing as if you're sitting in a train looking out the window and your eyes are flicking past the scenery. It's that same reflex that they're looking at. And by tweaking the stimulus, they can make it so that you see motion when there isn't really motion there, and your eyes still move, so they can measure it. And they're going to be looking at the sort of, by changing the qualities of the stimulus, they're going to be looking at the different contribution of expectations and what's coming in through the visual system, particularly in the peripheral visual field. So they realize that in macular degeneration, it's the spared visual periphery that's there, and it may be something to do with that that's causing these Charles Bonnet syndrome hallucinations in that particular condition, at least. So this is kind of an early stage of research. And finally, things that we're going to be doing, we're looking at the SHAPE study and the impact of Charles Bonnet syndrome on memory. Now, for those of you that can see the screen, this is a graph of memory changes over the 18 months of the SHAPE study. Now, you don't, even if you're not visually impaired, you will not be able to see the difference between those patients who have Charles Bonnet syndrome and those that just have eye disease, because there is no change in your memory. There's no decline in memory in either of those groups over the 18 months of the study. However, we do know that within the Charles Bonnet syndrome population, there's a handful, a very small number of people who do go on later to develop memory problems. And what we're looking at is, are there any clues in the types of hallucination that they've had, or the way these hallucinations are experienced, that will predict what is going to happen to their memory 2 years down the line? Because as you can imagine, it's very important that we don't tell these people, oh, you've just got Charles Bonnet syndrome and there's nothing that needs to be done. If we can find these people at this very early stage of a memory problem, they need further tests, and they may be able to benefit from treatment to prevent any further memory changes. So that's a very important thing. But just to re-emphasize, it's only a handful of people that would be in that position where Charles Bonnet syndrome is an early sign of memory problems, because for the overwhelming majority, there's no future memory decline. So I'm going to end there. I think, so I took from 1760 to the current day, so 260 years to cover past and present. And I really hope it's not going to take another 260 years to get to the future. But I hope that I persuaded you that there are things just around the corner in terms of treatment. And I have every expectation that in the next year or the year after Esme's Umbrella Days, we'll be showing new evidence as to what it really is that causes Charles Bonnet syndrome, what really is the difference between those people that have hallucinations and those that don't, a better understanding of the mechanism. And of course, that's really important, because by understanding the mechanism, we can develop new and effective treatments. So I'm going to end there. I'm passing back to Judith, who's going to introduce Kat, and I thank you for your attention.
Dominic, thank you very much indeed. That was absolutely fascinating as always, and very hopeful too, which is great. So our next speaker is Dr. Kat De Silva Morgan, and she is going to explain the work that she has been doing at Newcastle University. So welcome, Kat. Thank you so much.
Sorry about that. I was muted. I seem to be very unlucky with having technical difficulties today. So thanks a lot, Judith. Yeah, my name's Kat. I'm going to be talking about the research that we've been doing at Newcastle University, and specifically some of the research which Esme's umbrella helped to fund. So as you've already heard from Dominic earlier, one of the most interesting questions that we can ask when it comes to Charles Bonnet syndrome is, why is it that some people with eye disease experience hallucinations and other people with eye disease don't? So that was one of the first things that we really wanted to address. So in order to do this, we decided to ask a group of people to come and help us out with some of the research. And we were able to get participants who, 19 of which had Charles Bonnet syndrome. So these people were experiencing visual hallucinations, usually a couple of times a week. So quite regularly at the time when they entered the study. But on top of this, we also asked 18 people who didn't have hallucinations but did experience sight loss. So these were usually people who had eye disease such as macular degeneration or retinitis pigmentosa. But the very important part about this was that they had never experienced visual hallucinations before, so they were separate from the Charles Bonnet group. We also tried to match them very closely for certain key aspects. So as we've already heard from Dominic earlier, one of the things that people have suggested is quite important is things such as the age of the people who are experiencing the hallucinations. As we know, there's quite a lot of other conditions, for example, that can cause hallucinations, and this can also be related to things like age and also their visual acuity as well. So because we know that visual acuity can have an impact on people's hallucinations, we also wanted to make sure that the two groups were quite evenly matched for that. Now, how do we look at differences in the brain? So there's a couple of different techniques that we can use. And in this study, we were focusing on two main areas. And these were areas that were allowing us to look at the way that the activity changed during certain situations, or what the activity was like on a normal basis in these two groups. So the first one that we used was the brain imaging. And there was two specific types of brain imaging that we were interested in here. So the first one was what we call functional magnetic resonance imaging. And this allows us to look at the way that the brain responds to, for example, different tasks and the sort of activity that is then produced in specific regions of the brain as a result. So in this case, we were really interested in what was going on in the visual part of the brain. And another type of imaging that we were using is something that we call magnetic resonance spectroscopy. Now, Dominic mentioned this just before. And what that does is it allows us to measure the concentrations of different brain chemicals in specific regions. And in this case, we were really interested in what was going on again in the visual cortex. So we wanted to know whether there was a difference in the concentration of certain brain chemicals, specifically in this case, the inhibitory brain chemical, which is called GABA, and whether that differed between people with Charles Bonnet syndrome and people without. And another area that allows us to look very specifically at the type of hyperexcitability, which is that key term that keeps coming up in regards to Charles Bonnet syndrome, was occipital transcranial magnetic stimulation. Now that's a bit of a mouthful, but we refer to it as TMS. And what this does is it targets the visual part of the brain and allows us to measure what sort of resting state level excitability is going on in these people. So how likely are they to respond to this external stimulation gives us an idea of how excitable the brain is normally. So, on to some of the results. We actually found that the results that we found were a little bit surprising, actually. So as you saw in one of the previous slides from Dominic, what we were expecting to see, particularly with the functional scans, was that people with Charles-Bonnet syndrome would actually have more activity going on in the visual cortex, which is that part of the back of the brain, when we asked them to do, in this case, an eye movement task. And this we expected would point more towards this idea of hyperexcitability. So people with Charles-Bonnet are more likely to have all this excess activity there than people who don't have Charles-Bonnet. But we actually found the complete opposite, which was very surprising. So as you can see from these lovely images, if you're able to see the slides, we've got these pictures of these brains, and we have the controls who are showing all of this nice yellow activity in the visual parts of the brain. And then our Charles-Bonnet participants have actually got a very small amount of activity in that area of the brain. Now, when we were looking at the very specific areas within the visual cortex, and these are areas that are more developed for specific functions when we are using our vision, we found that the area that seemed to be most affected by this disparity in activity was an area that we call the ventral extrastriate. Now, this is quite interesting because in previous studies, and in fact, one of the studies that Dominic did now over 20 years ago, found that when people were having hallucinations with Charles-Bonnet, the area that seemed to show a really large increase in activity was actually this area, the ventral extrastriate. Now, what we're finding here is that when people aren't having hallucinations, this area actually has much lower activity than a person who has eye disease or has sight loss but doesn't experience the hallucinations. And this is part of what we call the visual association cortex. So this is a region that is usually used for quite a lot of different forms of visual processing. So it's quite an important region. So it's quite interesting that there is such a lower level of activity there. So we also then wanted to look at how the actual hyperexcitability was related in people with Charles-Bonnet syndrome. So using this technique, like I said, TMS, we perform this by putting this interesting looking magnetic coil to the back of the head. So for people who can see the slide, it's the picture on the left-hand side, which has got this, this interesting figure-of-8 coil set up. Now, what we do here is we place this on the back of the head and we produce a very brief magnetic pulse. And what this magnetic pulse does is it very briefly increases the amount of activity that is going on in that part of the brain. So in this case, it's in the visual part of the brain. And what can happen with that is that it can cause people to see a very brief flash of light. And that's something that we call a phosphene. Now, people who have a naturally very excitable cortex already are more likely to get these flashes of light at much lower intensities of stimulation. So it takes a lot less stimulation to produce that response. So we were quite interested to see whether the levels, what we call the phosphene threshold, whether that differs between people with Charles-Bonnet and people without Charles-Bonnet. And what we found was, if you can see the slides, we've got this graph on the right-hand side, which shows the spread of these phosphene thresholds in the two groups. Now, these weren't statistically significant. So by the statistics, it suggests that there isn't actually a difference in hyperexcitability between people who have Charles-Bonnet and people who don't. However, as you can see from the graph, there's a lot more people with these much lower phosphene thresholds in the Charles-Bonnet group. And what that suggests is that people with Charles-Bonnet are more likely to show this much higher excitability in the visual cortex. So a lower phosphene threshold is synonymous with higher excitability in this case. So that was quite interesting. And also the people with Charles-Bonnet syndrome were also likely to have more of a spread of these phosphine thresholds. So they were more likely to have much more variability in how excitable their visual cortex was. So that was interesting. But how does that fit in with the imaging results that we found, in which people who have Charles Bonnet seem to have much lower activity in the visual cortex during this eye movement task? Well, when we looked at this, we actually found that people who had this higher excitability as measured by the stimulation also had this lower level activity during the functional scans. So higher excitability was related to lower activity during the functional MRI. So again, that was something that we weren't really expecting. And it was interesting to try and unpick this because, as Dominic had mentioned before, it suggests that actually the hyperexcitability idea that we've had for many years previously, it might not be quite as simple as that. There's definitely seems to be a lot more going on there. So a couple of the things that we could potentially think as an explanation for this is that it might be that people with Charles Bonnet syndrome have got a lower level of what we call background noise. So during this eye movement task, the brain wasn't really producing a huge amount of activity. And that might be because the brain is actually trying to overcompensate by reducing the amount of activity that is there so that it can pick up any visual signals that come through. And this is maybe a way of potentially maximizing how much people can see who have sight loss. But the problem with that is that then any internally generated activity, so this is normal activity that the brain puts out at random times for no apparent reason, and this happens to everybody regardless of whether they have sight loss or not. This random activity is actually then being picked up by the brain as being an actual signal. And then that translates and becomes a visual hallucination. So the brain is picking that up as an actual visual signal and telling you that you're seeing something that isn't there. Now, what that may mean in comparison with the controls, so the control group, which is the people without hallucinations, is that their activity in the background is a little bit higher, which means it's almost drowning out these little spikes of activity that shouldn't be there. So they're not getting the hallucinations because it's not rising above that level. Another potential explanation might also be the way in which we measure this sort of activity using the functional scans. So for example, when we ask people to do eye movement tasks in a scanner, what the scan is actually measuring is the difference between when people are moving their eyes and when they're not moving their eyes. So what it could be is that actually people with Charles Bonnet syndrome, because they've already got so much activity going on in their visual cortex, when they move their eyes, the difference is very small. You know, there's only so much that the brain can ramp up in terms of activity during this task. So the resultant effect is that we only see this very small level of activity as a result afterwards. Whereas the people who don't have hallucinations, because their normal baseline activity is a lot lower, the difference between when they are moving their eyes and when they're not is much greater. So that might be another potential explanation here. And this is one of the reasons why research into what we call like the resting states, so the type of research that the Oxford group are now going to be doing, and how the different areas of the brain are connected and how they communicate with one another, that is now really important research, because that could help us to unpick what this particular finding actually means. Now, we also, as I mentioned, looked at the different brain chemicals in different areas in the visual part of the brain. And again, this was slightly surprising in the fact that we didn't find any difference really between the two groups. So there was no significant difference in how much of this inhibitory brain chemical there was in the visual part of the brain in people with Charles Bonnet and people without. But what we did find was that the amount of variation, again, this variability that was really important with the hyperexcitability, was really vast again. So in the group with Charles Bonnet, there was a lot more variability in whether people were going to have a really high level of GABA or really low. And people also seemed maybe slightly more likely to have the lower levels of GABA in the Charles Bonnet group than the control group. So this is again something that we're going to need to unpick in future as well. Is there something else going on here with these brain chemicals? And is this variability, is this going to be one of the key things that we need to investigate further? So in summary, we had quite surprising results. We didn't necessarily find evidence that we were expecting that people with Charles Bonnet just have a blanket hyperexcitability in the visual cortex. They're more likely to be hyperexcitable than people without. That's not what we found. But we did find this interesting interaction between these lower levels of functional activity and hyperexcitability in the visual cortex, which suggests that there is definitely something different going on in the brain of a person with Charles Bonnet compared to someone who doesn't have it. So this is essentially one of those studies which is going to prompt a lot more further research, particularly into the way that different regions of the brain communicate. Another important thing for us to mention as well is that this is actually currently the largest study in Charles Bonnet syndrome which has actually ever been performed to date of this kind, so investigating these sorts of mechanisms. So it's a really good first stepping stone for us to be able to move on to future research with. And it's also a brilliant mechanism to be able to actually push forward this sort of research. So it's been a really successful study. So it's really nice for us to be able to present this and be able to move forward with it for future similar studies. Now, one of the other reasons why this research is quite important is that it gives us an idea of what sort of things we might need to target when it comes to things like treatment. And actually at Newcastle, what we then did from this is we used some of this information, particularly in terms of these variable levels of hyperexcitability, and we tried to look and see whether a form of brain stimulation, which uses an electrical current, which is called transcranial direct current stimulation, we wanted to see whether using that sort of stimulation to try and dampen down the likelihood of these spontaneous bursts of activity, whether this would help people's hallucinations. Now, I'm not going to go into too much detail on that here because I've not got all the time in the world and there's so much to talk about with that. But the takeaway from that was actually that this could be a really promising and effective tool for helping us to treat Charles Bonnet, as we found that this particular form of stimulation was really good at reducing aspects of the hallucinations, such as the frequency and some aspects of how intrusive the hallucinations were. So it's definitely very promising, and even though it's a very early trial, it is definitely something that we need to pursue further in future. So this is a general update of what we have currently done at Newcastle. Thank you very much for listening to me, and I will hand over to Judith now.
Kat, thank you. Oh, I just waited. Thank you so much, Kat. That was absolutely wonderful and incredibly exciting, and a great start. So anybody else out there would like to do some research, just let me know. So next, we have, very fortunate we have Professor Maria Musiji. And Professor Musiji has been looking at CBS in children, something which is very close to my heart, and also how COVID-19, how the lockdown of COVID-19 impacted on people with CBS. So I will hand over directly to her. Thank you so much, Maria.
Thank you, Judith. Thank you for that lovely introduction and for inviting me to speak today. A big thank you to Dominic and to Kat for their explanations and updates. I'm going to go straight into our research. which confirms that children do suffer with Charles Bonnet syndrome. And as Judith says, then touch on the effects of the lockdown on Charles Bonnet syndrome. So I'm just, well, there we go, there are my slides. So next slide, please. So this is our paper published in the British Journal of Ophthalmology from September this year. And it outlines the largest case series of children and young adults with Charles Bonnet syndrome that's ever been documented. Next slide, please. So why did we conduct this study? Well, there is a lot of anecdotal evidence that we're not really asking families with young children or children themselves, or informing them that Charles Bonnet syndrome may actually occur in children. And I did a short poll of consultants at Moorfields and Great Ormond Street and asked them if they in fact queried this with any of their patients. And there was an overarching consensus that they didn't, and that it just didn't come into their mind that they should do so. Now, if we look at the scientific literature, there is a handful of cases of Charles Bonnet syndrome that occurs in the pediatric population, but we definitely need more evidence to present our case and to raise awareness amongst our healthcare providers. Next slide, please. So our methods, initially, at least to prove that Charles Bonnet syndrome does occur in children, was to search through the electronic patient records of all children and young adults less than 25 years of age who attended Moorfields Eye Hospital between March 2011 and January 2020. So that's a 9-year period. And we searched for keywords such as Charles Bonnet and visual hallucinations, and we collected all those case details. Next slide, please. And so the results showed that there were 13 patients identified that had either Charles Bonnet or visual hallucinations documented in their notes. Close to 70% of these patients were male. And the median age of Charles Bonnet syndrome onset was 11 years of age, and there was a range between 9 and 19 years. Now, most of these patients had reduced visual acuity, so the vision in their better eye was kind of middle of the chart, so where you can see ZONCR, so 3 letters down from the top line. But the vision in the worse eye was 1. So that was the top line. They could only see the letters on that top line. And of those 13 patients, only 6 were registered as sight impaired or severely sight impaired. Next slide, please. So the background sight loss disorder that was most common in all these patients, so in over 60%, was inherited retinal diseases. So these are conditions that are caused by a change in the genetic code, in the DNA, that essentially causes a disruption in the instructions of making a protein that works in the retina, the light sensitive cells at the back of the eye. And because that protein isn't working properly, the cells degenerate and die off, and that's what leads to sight loss. Next slide. And of those inherited retinal diseases, the most common disorder that we found in the children was a condition called Stargardt's disease. Now, we found this in 5 of those children, and this is caused by genetic changes in a gene called ABCA4. And essentially, this condition causes a macular dystrophy, so it affects the central vision. So it's the young person's version of age-related macular degeneration. It presents in childhood, and it affects 1 in 8 to 10,000 children and adults. And I've just put some pictures showing that the central vision can often be disrupted, and just some pictures of what the back of the eye looks like. So next slide. So the other inherited retinal diseases that led to this condition were Leber's congenital amaurosis, and this is a severe early onset form of sight loss where children can lose their vision within the first 5 years of life. Retinitis pigmentosa, common at all stages of life, but occurs in children with an incidence of about 1 in 3,000. Batten's disease, another form of a retinal dystrophy, but also affects the rest of the body and can actually be lethal, causing early death in those diagnosed with this. Birth eye defects were another large group that resulted in Charles Bonnet syndrome. So there was a patient that had a very small eye, underdeveloped eye called microphthalmia, with a cleft in the eyeball called ocular coloboma. Another child was born with their whole eyeball being defective, and it resulted in it kind of shrinking and becoming essentially blind. And then another child was born with a condition that affected the retina and the jelly in the eye, a vitreoretinal dysplasia with various other ocular problems. And then a couple of children had a problem with their nerves. So one, again, was a genetic problem involving the nerve at the back of the eye, and it was slowly degenerating and not passing signals from the eyeball to the brain. And another patient had a spontaneous bleed in their brain that affected their eye and their nerve. So that was a secondary cause of an optic neuropathy. Next slide, please. The one case that struck me from the cohort was the patient that was actually born with the small eye and the cleft in their eye, because that actually affected just one of their eyes. That was the left eye. The right eye was otherwise completely normal and healthy. That patient was reported to have features of Charles Bonnet by an optometrist. And it was a 12-year-old child that actually then admitted that they'd been seeing these simple hallucinations since the age of 6, but hadn't told anyone about them. Now, this case, the interesting part is ties in with what Dominic said, that patients that see halfway up the chart or better have a 20% chance of developing Charles Bonnet. With this patient, they have a normal healthy eye, so can see everything perfectly. And the other eye has a structural birth defect, which occurred within the first 8 weeks of pregnancy. And you would think that a child that is born with that would have been accustomed to that level of sight loss. But still, unpredictably, they develop Charles Bonnet syndrome. And it just is a warning to healthcare professionals that we still can't quite predict which patients are going to develop Charles Bonnet syndrome and which aren't, because I wouldn't have put my money on this patient developing that. Next slide, please. So the findings, so 8 of the patients described these simple hallucinations, flashing lights, spots, linear patterns. 3 patients experienced the more complex hallucinations, so faces, menacing faces in one case. Forgive me if my pronunciation is distorted here, but prosopometamorphosia, where, as Dominic explained, you get these altered perception of faces where certain parts of the face are very distorted. And one patient described seeing animals as well. And 2 patients reported seeing both these simplex and complex hallucinations. Next slide, please. So which of the healthcare professionals reported these cases? Well, the majority, just under half, were reported by actually junior doctors in training. About a third were reported by optometrists. Consultants only reported 3 cases. And the most common management decision was to provide information, for example, signposting them to Esme's umbrella, or just providing reassurance that potentially these would resolve, but clearly with no basis based on Dominic's talk. What was worrying was that 3 cases had no management documented in the records at all. Next slide, please. So the impact, well, as you can imagine, the complex hallucinations caused more fear, anxiety. Some patients reported disruption of their sleep, reduced appetite, aversion to food. And you can imagine that if they're seeing creepy crawlies on their plate, then they're not going to really want to eat food. Sadly, one patient actually had to drop out of university as they found that the hallucinations were so disruptive and anxiety inducing that they couldn't concentrate on their work. And one patient said that the hallucinations were not upsetting or disruptive. But again, 50% of patients had no documented impact on their lifestyle and well-being, which means that we're not asking these questions appropriately to patients, and we're certainly not documenting them. Now, we know some adults can rationalize these hallucinations. They can understand that they're not real, especially, as Dominic says, if you're forewarned, you're pre-warned and forearmed. But previous case studies have shown that children, especially those under 8, can believe that these hallucinations are real, and this can lead to maladaptive responses. So it can impact on their health and well-being. Some older children may start to question whether they have some psychiatric diseases like schizophrenia again. So we have the older adults that may start to question whether they have dementia. Schizophrenia may weigh on their mind if they're teenagers and young adults. It can have an impact on their relationships, on schooling, on their career choices. And this can all have a very long lasting and devastating effect on them. And we don't yet know how long these hallucinations last for. Next slide, please. So that's just a kind of taster of what we've found so far. Our next steps are to conduct a multi-center national prospective study to try to ascertain the prevalence of Charles Bonnet syndrome in children. We're going to be working with pediatric ophthalmology specialist tertiary referral centres across the country, where they see children with these congenital and genetic eye diseases. We're going to be collaborating with the British and Irish Orthoptist Society, as orthoptists will be measuring the vision of these children across the country and can begin to raise these questions and also raise awareness of Charles Bonnet syndrome with parents. We need to understand how common this condition is in children and its true impact, and then how do we manage these patients? Because it may not be enough just to provide coping mechanisms, it may be, but we may need to explore the other treatment options that are available to patients now. So I'm hoping to give you much more of a research update in the coming year. And I'd just like to thank Thomas Pocklington Trust for supporting this research. So next slide, please. On to the second part of the talk, which is looking at the effect of COVID-19 on Charles Bonnet syndrome. So over the first lockdown, I felt quite bad because a lot of our genetic eye disease patients had been cancelled because they were deemed non-urgent. And as you may not be aware, but I am a specialist in genetic eye disease. And so I reached out to 3 of the main UK sight loss charities that see or rather care for patients with genetic eye diseases. And that's Aniridia Network, Retina UK, and Microphthalmia and Ophthalmia and Coloboma Support Charity. And I offered to undertake voluntary Ask the Expert sessions so that patients across the country could get in touch and discuss their conditions with somebody who understood what those were about and just give some guidance and reassurance over that lockdown, especially if their appointments had been cancelled. Now, interestingly, I had a lot of patients contact me that began to describe worsening hallucinations, increased frequency of their Charles Bonnet syndrome. And so I was actually referring quite a few patients over to Judith to kind of get in touch and provide some support for them. But it made me think that we potentially needed to do some more investigation as to what was going on with the link of Charles Bonnet and the effect of the lockdown and pandemic. So next slide, please. So my team contacted 45 patients with Charles Bonnet syndrome towards the end of the first lockdown. And the mean age of the patients was about 70 years of age, and 60% were female. Just over 40% had macular disease. And we asked all these patients opened and closed questions about the features of their visual hallucinations during the COVID-19 lockdown, if they'd got worse, if they'd become more frequent, and also any perceived episode triggers that had contributed to any changes. Next slide, please. So we found that over 50% of patients actually reported an increase in frequency of their visual hallucinations. Close to 50% reported that there had been changes in the nature of these hallucinations, so they were becoming more sinister. Over 50% reported changes in their emotional response to their hallucinations. They reported them being more fearful and inducing more anxiety. And currently there is a very good podcast available through Thomas Pocklington Trust that Judith, a patient called Nina with Charles Bonnet, and my co-investigator Lee Jones have done. And Nina, the patient, really nicely describes that in periods of stress, how her hallucinations match her emotions, so how they get more sinister and frequent during those times. And so this is kind of proving that actually that's the case. 67% of patients reported feeling greater feelings of loneliness quite clearly over the pandemic. But what was also worrying was that only 40% of those patients had actually accessed support services. So 60% of patients were just coping on their own and not reaching out for help. Next slide, please. So the perceived triggers, well, loneliness, close to 70% perceived this as a trigger. Nearly 50% thought that the reduced physical exercise, the lack of going out and moving, and you can imagine, we've heard in the news and across the board that patients with sight loss have really struggled to go out, that they find it difficult to shop because obviously they use touch more, and they've been bumping into people, and it has been a very difficult time for them. 30% attributed the increase in hallucinations potentially due to watching and reading chronic stressful news. So the number of cases of COVID in the last 24 hours, the number of patients dying, Boris every day giving us an update, all of that had contributed to their psychological state. I suppose, thankfully, only 25% of patients had attributed a trigger to reduced access to healthcare. So next slide, please. So what can we all do to help? Well, staying in touch with each other is absolutely key, even if it's just a phone call, an email, but please do stay connected. Community support groups are also really important. And we've seen this from previous years, that it's those community support groups that have really helped with the discussions on Charles Bonnet and brought this out so it's not a taboo subject. Hospitals, well, we really need to try not to cancel our appointments. I have converted all my appointments to virtual consultations, as has a number of centres across the UK. So more virtual contact. And if it's not with the consultant or a doctor, eye clinic liaison officers, genetic counsellors, nurses, we need to try to maintain that contact with our patients. And then please access the charity helplines. There's Esme's Umbrella, RNIB, Retina UK, Macular Society. They all have charity helplines where they're willing to receive calls from you to hear if you are struggling during this really, really difficult period. Next slide, please. So I'm about to end, but I wanted to leave you with just a resource that you may want to access. So over the last 18 months, myself and my team have been putting together a website called gene.vision, which is essentially an A to Z on genetic eye disorders. However, we have included a very in-depth section on Charles Bonnet syndrome, and that is for every one of you to access if you need to. But it gives you a really nice introduction into Charles Bonnet, tells you about the coping mechanisms, how to access care, all the resources that are available to you. And it has been looked through by Judith and various others to make sure the information is accurate. The website is fully accessible for all those with visual impairment and sight loss. It works with all speech programs, magnification, and it's going to be launched on the 1st of December. So please do use that to learn more about Charles Bonnet, but also if you've got friends and family, then you can refer them to that so that they can get a better understanding of the condition. Next slide, please. So with that, I would just like to say a massive thank you to Judith. Without her, I really probably wouldn't be here and wouldn't be researching into Charles Bonnet syndrome. So thank you for all your endeavours. All of this is a massive credit to you, Judith. Thank you. To Dr. Lee Jones, who is the psychologist who's been working on these projects, massive thank you to you. Again, without your expertise, I wouldn't be presenting this work. Thank you so much for your hard work. And Lara Ditzel-Finn, who's been working with Lee. She is a support worker in the Eye Clinic Liaison Service at Great Ormond Street. Thank you again. Some of you on this webinar may have heard from her and may yet do so in the future, but do get in touch with us. If you have any questions or want to get in touch or involved in the research, please email me on m.musaji@nhs.net. And feel free to get in touch with Judith if you need that email address. Thank you to Thomas Pocklington Trust, and thank you to the Wellcome Trust for funding me and the NIHR. Thank you very much.
Marvellous, Maria, thank you. And also my thanks also go to Lee and to Lara, without which, as Maria says, it would be impossible. Right, so now we move on to Keith Valentine. Now, Keith is very important in the RNIB. He is the Director of Development, but for today, he is going to represent the Charles Bonnet syndrome community and explain what it is like to live with the condition. So, Keith, thank you so much. Unmute yourself and off you go.
Can you hear me?
Yes, we can.
Oh, it's a huge relief. So bear with me a second, sorry. Let me just make sure that my camera's off. Apologies to everyone. My partner, I've got a number of apologies actually before I start. I'd intended to start thanking Judith, but the job's been done there, so I'll wait till the end so it's still fresh for everybody. I can't turn my camera on, although if I do, apparently it switches off my broadband, so I disappear altogether because of some work that's going on upstairs. And the final apology, I have bronchitis, so I may need to pause now and again to get a drink should I go into a coughing fit. Judith, very, very generous in the way that you tee me up there as someone of importance in the RNIB. What I think I am is fairly unique in the sight loss sector, in that I've managed to work my way into a position with some authority in a charity, and also to have sight loss. It's startling what a rarity that is, I think, in the charity sector, which is probably a conversation for another day. But statistically, I know that I am one of only 25% of those people of working age affected by sight loss that are working. I guess further unique in the sense as well that I have Charles Bonnet syndrome. And what I'd like to do today in the time I've got available is if you like, tell you a bit of a story about myself, and also from that, I think, talk about two principal things, concepts or factors that I think are at play for patients. One is confidence and the other is community. I feel quite humbled to be following the expertise that's gone before, and I have to say, as a patient with Charles Bonnet syndrome, to see the quality and progress in the thinking of the work that's been demonstrated from the times that I've had contact with it, it's really it's quite exciting. So a little bit about me and my story. I have retinitis pigmentosa. Without using the technical terms, everyone in my family that has it can pass it on. There's a 1 in 2 chance of children having it, and sadly my daughter does have it, my son doesn't. But also that we don't have carriers in our family. I come from a rough and ready gang of EastEnders. In some instances, the word gang is appropriate for certain parts of the family in Barking that we don't talk to very often. But you know, we are, in essence, I think, quite a broad cluster of people directly affected by retinitis pigmentosa in various ways. And Charles Bonnet syndrome, I discovered in the last few years, since first having the conversation with Judith and figuring out that was going on for me, I then started to figure out it was also going on for very many other members of my family, and I'll go on to talk a little bit about that as well. I started off, all of what I'm going to say is under the caveat that sight loss has improved me immensely. I think I'm a far better person, a far more connected person, and a far more engaged person than I might have been. I started out principally concerned about one thing, and that was making money and hopefully owning my yacht in the Mediterranean by the time I reached this age. I have to say, though, it's an immense pleasure to be with you all today. I wouldn't give up the yacht now for this. But I, at a point where I got my company to a certain point, the retinitis pigmentosa that I was diagnosed as having when I was 11 took its effects to another level. And this was before the existence of iPads and the various technologies, and the best technology had, I think, were Braille and large print and those sorts of things. And if I'm honest, the loss of sight for me was a substantial event in my life. Whilst I'd had a diagnosis since I was young, I'd kind of been the boy who cried wolf, with it, happy to talk to anyone who wanted, thinking that I understood what it meant and what its implications are, and just getting on with life as if it wasn't going to happen. So it was, you know, an utter and substantial impact on me. I mean, the advantage with having, it's a funny way, do forgive me if I say anything that crosses any lines. I was about to say the advantage of having inherited retinal disease is that there are often other people in your family that have it too. And I have to say that in the process of me losing my eyesight, my mother, grandmother, and various others that had it were definitely in the. I'm going to sound like I'm doing a disservice. They're wonderful people, but it was, you know, have a cup of tea and get on with it. You know, very many of my family with retinitis pigmentosa over the years have worked with the eye disease, and transpires very many of them have worked experiencing Charles Bonnet syndrome as well. The most colourful of which was the Uncle Bill, who was a butcher who worked with retinitis pigmentosa and Charles Bonnet syndrome, where he saw animals. So the joke in the family is that we call him Uncle Thumbs, because that's the only finger that he had left. But he was, again, an inspiration to us all. As I started to lose my eyesight, I started to develop, I think once the initial kind of significant reduction had come, and I would consider it to have been stabilised, I started to see odd and unusual things. Initially, wood grain seemed to be cropping up everywhere, and then strangely staircases in pavements seemed to materialise. And as anyone who knows where the RNIB is, I have to routinely walk past staircases in pavements on Euston Road, and I'm still not entirely sure how many of them are there. And then over time, it seemed to intensify. I was very interested in the research earlier that was pointing to sort of, you know, 18 months and it passes, or, you know, it can go on for a certain period of time, but it will fade, because certainly for me, it's still an active experience. And over the first 3 to sort of 4 years of it happening, it worked towards eventually me seeing a First World War soldier with a significant facial injury that would crop up. Incidentally, the first time that occurred, I'd been out to the pub to watch England in the rugby, and I may have had a half a Guinness. Got back to the flat and was first through the door, and himself in his uniform was stood in the front room. I sort of jumped, came out of the room. Obviously, my partner was sort of terrified. Particularly, I think, because at first I thought it was a burglar, and then probably the worst kind of burglar, the one that doesn't run away when you say, "Who are you?" You know? And then obviously went back in the room, and the thing had disappeared. I actually, in terms of Charles, the experience of Charles Bonnet, it kind of leveled out over a period of time, and I found that eventually I kept it to myself for a long period of time. I kind of, other than my partner, you know, you spend all your time with it, wasn't something I'd talk about openly or really properly understand what it was, just knew that it was happening. But eventually I spoke to my mother, who, having had, you know, RP pretty much starting at the same time as me in a similar pattern, and just mentioned this had been happening. And she, being the East End stalwart that she is, said, "Oh yeah, I get that. See snakes everywhere." I did think at the time she might have mentioned this, so I could be prepared. But I think that the point, I mentioned confidence and community. For me, as somebody that's got a family that's I think overcome many of the challenges that you can face in losing sight loss and managed to keep working, and those sorts of things. That what it's also given me is reference points and people that I can talk to comfortably about things that are really you know, significant and difficult. And quite frankly, to see, you know, something with horrible facial injuries, and, you know, it's not uncommon for me also to see facial injuries on people that are passing in the street and those sorts of things. It takes a lot of getting used to. But I think that having come from the background that I come from, and being able to kind of, you know, able to work hard and progress, I've maybe got a kind of infrastructure around me that's fed my confidence and enabled me to reach for community. And it's kind of at that point that I want to pivot to reflect on what Charles Bonnet syndrome can mean for patients that perhaps haven't got that. And I was really struck by the last presentation there about children and their sort of assimilation of these experiences into you know, the patterns and the way they live their life and the psychology of it all, and those sorts of things. And I'm also, and have been, acutely conscious of the experiences of people as they're older, or people perhaps with sight loss where they're isolated and haven't got the kind of confidence and community that somebody like me would have been able to develop over time. And I think it poses quite a significant question. One of the things that's always struck me about Charles Bonnet syndrome, and as Judith and I have spoken and spoken to other people, and Dominic in particular, around the science, that, you know, there are obviously great things that we can do, and I recognise that, you know, people that have got really intense Charles Bonnet syndrome, that sad story about the student that had to give up, you know, it can have such a profound impact on you know, people's sort of sense of self, you know, and what's possible in life. And I wonder whether, beyond the science, there is something about living with a condition like Charles Bonnet that I think also, you know, elevates and indicates what it's like to live with sight loss in itself. You know, that if you're living with sight loss in a way that is pushing you towards isolation, or that undermining your confidence and your sense of identity, or significantly restricting your ability to navigate and move through life. Charles Bonnet syndrome, I think, runs in parallel and overarches. That can be another factor that drives people inward. I guess particularly with elderly people, and it's come up, people's sense of their, you know, their you know, whether their mental health or their problems with dementia or whatever are degenerating, and that Charles Bonnet syndrome is an indicator of something other than what truly is I would suggest, likely often in the way that people are thinking about themselves. Which pushes me to the point, the work that Judith's done with Esme's umbrella is really impressive around the research. But there's something for me as well about doing more than coping and finding a way to live with the conditions that will ultimately, with Charles Bonnet syndrome, only mean something if it's detrimental to what we're able to do with our lives as visually impaired people. I think when the soldier crops up, I don't see it as a fearful thing anymore. I don't like being surprised by it, I'll be honest with you. But then I've got kids that slam doors and jump into rooms, and that also upsets me a bit. But it's, you know, as you get used to these things, I think, you know, it's possible to, as it is with sight loss, it's possible to you know, to plan and plough a life for yourselves that is as, you know, kind of as good as anyone else. And I see a personal responsibility, and I've always wanted to be involved with Esme's umbrella in finding the language or demonstrating the ways of living and coping, and trying to share that information in a way that, whilst the incredible guys that are working on the science of it all have been on the call earlier, that we have a prospect of life now, as well as what may be possible when cures and treatments for Charles Bonnet syndrome become available. I think, and I'm really sorry to talk about myself. I'm not trying to make out that I'm any different to anyone else and anyone else's experience. I think what I'm saying is that I feel like I've been incredibly lucky in my life broadly, and that as I look to the prospect of my daughter with retinitis pigmentosa and what may come for her next, and the real prospect of Charles Bonnet syndrome, I mean, I don't know if it's inheritable or not, but I know my mum had it and my grandmother had it and I've got it. So there's a coincidence for you in the three of us. But I wonder what it would look like for, you know, Lucy as she starts to imagine her life going forward. And that sense of connection, you know, that sense that, you know, you could take all, you know, put me in the grave and take that disease away from Lucy and I would vote for that. But that's, you know, what I want for her is the best possible life. All I'm articulating is the same thing we all feel. That people with Charles Bonnet syndrome and sight loss are human beings, incredibly capable of surprising each other with what we can cope with. And my substantial hope, and I think the thing I kind of wanted to say really clearly today is that when I recently, it was about 18 months ago now, did a speech at the Royal College of General Practitioners as part of the training programme, and Judith and I were both on the stage there. I don't know if you remember, Judith, we did a little bit of a survey of how many people were aware, and I was comforted by the number that were, and worried about the rest that weren't aware of it. I really believe that from the human side of this, while the science is being worked through, there is a job for people like myself and others that are kind of, you know, are living with it in a positive way with confidence and community, to articulate and support patients that are going through where the psychological impacts and the mental health and well-being impacts of it could be utterly disproportionate to the reality of what it means in terms of, you know, the horrible and upsetting things that you can see. So to close, can I just say this? I'm coping better with Charles Bonnet syndrome because I met Judith Potts. And I'm very, very grateful for that. So we'll always turn out to do a talk, even though, as you can see, this, well, firstly, I'm glad I didn't cough through that. That's a sign I'm getting better. But also that there's something that Esme's umbrella means to patients, or certainly means to me as a patient, that is, if you like, greatly inspired by the science, but beyond the science, talking about something, sharing something, reaching out to find community, and hopefully to help people build confidence with it, gives patients a prospect of working through their lives, as they will need to do with sight loss anyway. And I would, for me, urge anyone on this webinar that's experiencing this to certainly hopefully take hope from what I'm saying, but also to say that, you know, we can get through this together. And whilst sight loss can lead to isolation, and was mention of the COVID period where I was part of the survey and mine did get worse. The soldier ended up leering at me through my kitchen window while I was cooking my breakfast one day, which I was grateful for. I told him to behave himself. I don't know if he listened. But just to say that these are incredibly difficult times. Sight loss can be overcome, but it requires confidence and community to do it. And that Charles Bonnet syndrome, from a patient's perspective, I think the more we understand, the more that we reach out to other and find peer support. Through the work that Judith and other organisations are doing, the better it is. And just to commit as well, I mean, whatever the scientists need to continue the research, I hope we as a patient community can work together to make sure that they get that, to take the understanding forward. And thank you for your time today.
Keith, thank you so much. That was very inspiring, and thank you for your kind words. Our last speaker is Dr. Jane McNaughton, who is going to explain CBS from the optometrist's perspective. Thank you so much, Jane. Over to you.
Lovely, thank you very much. And thank you very much, Judith, for actually inviting me here today. It's been a great privilege to talk amongst you all. So I just wanted to mention something about the optometrist perspective. And first of all, before doing so, I thought I might just sort of briefly explain as to what I am as an optometrist and who I am and where my background has been. So primarily, I started off life actually at Moorfields Eye Hospital. So I was a hospital optometrist in the late 1980s, and that's where I started my training. And my interest became very, very quick within the sight loss sector, working under the now late Janet Silver, who was then the head of the optometry department. But for the last sort of 15 years or so, I've now been working at Leicester Royal Infirmary, where I help to run the low vision service for our sort of Leicestershire and Rutland. And we have a great privilege of being able to work jointly with our local sight loss charity, Vista. And it's a huge benefit to us as optometrists working within the sight loss sector of working directly with and alongside our visual rehabilitation workers. But I also work within the university sector as well. So I'm over at Anglia Ruskin University in Cambridge, where I do some teaching towards in low vision and other related subjects with my colleague, Associate Professor Dr. Kez Latham. And we are teaching to our opticians and optometrists regarding the impact and management of low vision within that sector. So that's sort of basically my background. But what was quite interesting is when Judith had asked me to join this webinar, I decided to reflect upon when I became aware of Charles Bonnet syndrome. And I appreciate this has been around for several hundred years, but having been in the sight loss sector for nearly 30 years, I can pretty much guarantee I was not aware of Charles Bonnet syndrome all that time. And myself and Dr. Latham actually had a discussion about this fairly recently, and I think we both came to the conclusion that our awareness was very much more enhanced around about 10 years ago, if possibly just slightly before. And both of us have been working within the sight loss sector for our entire careers, which now span over at least 3 decades each. So apology to Kez on that one. So we were sort of only really aware of Charles Bonnet syndrome really within the last 10 years. And, within the optometry profession itself, I would say it's even sort of less time with that. But I'll hit on that in just a moment. So first of all, I also decided to sort of mention the other colleagues within the sight loss sector and asking them about, their awareness of Charles Bonnet syndrome. And for those opticians and optometrists within the sight loss sector, I found that they have been less aware of it. In fact, comments were coming back saying, I didn't really know about this until the last few years, or patients don't actually mention it at all. And the best one for me is, it seems to be a very rare condition. Which my sort of first response to this is that a condition will, the condition will only appear rare if we don't go looking for it in the first place. And I think for me, this is actually where the sort of the proactive nature of us as optometrists and opticians within the primary eye health sector, we need to be going out to discuss this and being proactive. And for somebody who's been working in the disability sector, we don't just go looking for it, but we need to anticipate it as well, and to be able to discuss with our patients the possibility of Charles Bonnet syndrome appearing. So understandably, I went to speak to many other kind of my colleagues within the sight loss sector, and there's a group of us that we chat and meet regularly online. And I asked them about, how do you go about asking or being proactive about Charles Bonnet syndrome? All of these practitioners are experienced low vision practitioners, and all of them actively ask about Charles Bonnet syndrome. So whether they actually have a tick box within the record card or ask about it in advance or whatever, they're all actively asking about CBS and making appropriate sort of records of doing so. But I would say that's probably a relative minority within the optometry sector, which is disappointing. However, it's only seems fair that education and training is the way forward. And I'll touch on that in a moment. But I think certainly amongst us as low vision practitioners, as soon as we became aware of Charles Bonnet syndrome, we started to act about it. We latched onto it pretty quickly. But I think one of the difficulties within the primary eye care centre, with the sector, with the high street optometrists and opticians, the lack of knowledge or being able to refer on or having that sort of ability to signpost patients if they mention CBS was something that was probably stopping them if they knew about it in the first place. So many years ago, I started doing some courses alongside one of the main providers of low vision aids in the country, Associated Optical. And I think I've managed to run 60 or 70 courses with them. And every time that I have had a team of people in the room, and these people primarily were rehabilitation workers, optometrists and opticians, I would ask them all about their awareness of CBS. So when I started these courses almost 10 years ago now, the response was relatively few and far between. No, never heard of it. And the only people that really had actually heard about CBS, and no surprises, is the rehabilitation workers. And they were there to then educate us on something that appeared to be apparently quite new. Now, because of a big push towards the education and training to our sector regarding CBS, I'm delighted to say that when I ask that question now within the training group, almost everybody has now heard of CBS. Pretty much everybody has heard of Judith and Esme's umbrella, and is all aware that being that anticipation and to discuss and being proactive about asking about Charles Bonnet syndrome is definitely the way forward. And most importantly, as eye care practitioners, it is and should be within our remit to be able to discuss this with our patients. At the same time, in the last few years, there's been a big significant push within the optometry sector to ask about emotional health, where this was not asked about many years ago. Of course, us within the sight loss sector have been asking about emotional health, and particularly there's a more push towards that based upon evidence-based practice in the last few years. Charles Bonnet syndrome should be and is a part of that as well. So going back to the education and training, certainly we over at Anglia Ruskin University do actively promote and discuss within our lectures and with our teaching the importance of asking about Charles Bonnet syndrome, how we go about asking about Charles Bonnet syndrome, and of course what to do about it if there's an actual yes coming back from our patients. And having spoken to Dr. Latham again fairly recently about this, she's been incorporating that within her lectures certainly over the last 6 years at least. I personally have not been there that long, but that's something that she has been doing within her training. Also within our profession, we have continuing education and training, or professional CPD, or continuing continued professional development. And certainly across the sector, a lot of our main providers of education and training, not just in undergraduate teaching, have actually been incorporating CBS within their lectures and webinars, which is, again, widened that knowledge to the greater optometry and optician community. So the College of Optometrists have been very proactive, so has the Association of Optometrists, and also the Association of British Dispensing Opticians as well, ABDO. And we often discuss this at our hospital optometry conferences as well. And also within, and having discussed within our specialist rehabilitation teams, their sort of move towards professional recognition and continuous professional development. Again, Charles Bonnet syndrome is something that is very much pushed towards the education and training of CBS within the Rehabilitation Workers Professional Network. So very exciting about what's going on about education and training, which is definitely the way forward if we as optometrists are going to be a primary source or a primary point of contact to our patients with sight loss. And as sort of going back to what Dominic was saying very early in this morning's discussions, that given that Charles Bonnet syndrome does appear in mild to moderate sight loss, this is certainly something that opticians in the optometry sector should be picking up and being part of their remit early on. I just wanted to sort of mention very briefly a piece of research that was done with some of my friends and colleagues over at the RNIB. I'm not sure if it's quite big enough, but for those of you who are able to read this, this was a poster that was presented a couple of years ago, and it was an audit study looking at the number or the prevalence of patients reporting Charles Bonnet syndrome. And Louise Gow and Dr. Sarah Jesser and Bill Harvey over at the RNIB put this poster together. And I think what the main conclusions for that for us as optometrists and opticians are concerned is that it was previously very much underreported. We are not actively asking about it enough, and it is something that is well within our remit to do. So back into clinical practice, I think we are certainly duty bound to ask about Charles Bonnet syndrome. So I would like to see more additional education and training being pushed out towards the optical sector in the future. And certainly now that we have more evidence-based practice to actually give us that backing, that knowledge to be able to discuss very confidently with our patients what CBS is and who we can then signpost onto thereafter, after we've got that positive response, or even anticipate it in advance, is very important for us in the future. So just sort of in summary there, I think most of us who work within the sight loss sector are very grateful to Judith's push. She is relentless in what she has done. You just cannot say no to Judith at all. And we're obviously delighted the fact that Esme's Umbrella is a really important source of information. And I also wanted to say thank you very much to the team today to actually put everything together, because I do know that there's a large number of opticians and optometrists and rehabilitation workers, including some of my team over at Vista, that I work with, that have actually patched into today, which is absolutely delightful. And that's the way that we can then sort of educate our patients and our other colleagues going forward. So I just wanted to say thank you very much for listening, and I'll pass back over to you, Judith, I believe.
Thank you, Jane, very much indeed. And if you ever want me to come over and talk to your students and explain what I know, I can always quote Dominic if he hasn't got the time to come. Please just let me know and I'll be there. I'm going to hand over to Helen in a moment, who will have some questions, but I just wanted to say that I do think it is absolutely miraculous. This shows my age. Here we are all sitting in our own homes, and we have evidence given to us from such incredible people. So thank you, thank you, thank you. And also to Gareth and Sam, who calmed our nerves and made sure that we were not going to be too worried about the technology. And why would we be? It's been perfect. Thank you all for coming and for listening. It will be recorded, so I believe it will go onto YouTube, but you can easily get the link to that. And I think now I'm just going to hand over to Helen, who will give us a few questions to answer. Thank you, Helen.
Thank you, Judith. And can I also echo everything Judith said, and thank you so much to all the speakers today. It's been absolutely wonderful, and that is reflected in some of your comments. So thank you all for those too. So as Judith said, the presentations will be available on YouTube later today. So I'll send a link out for that. And I've also had some questions on the slides. If you would like the slides, please email me and I will send them over to you. You'll see on your interface that there's a little button, which is the poll button. If you click on that, there is a feedback form, and we'd really appreciate some feedback today. So that is now open, so please do go ahead and take a look at that. So now on to questions. The first one is for Judith. Is there somewhere to go for more support, and also for the coping mechanisms, and especially to help those more likely to fall over or to have falls?
I don't know where the questioner lives. If it's in the UK, then if you contact me on esmesumbrella@gmail.com, I can point you in the direction of an Esme's Friends group. There are coping strategies on my website, www.charlesbonnetsyndrome.uk. Falling over, well, Catherine at Manchester has yet to start her work, but what I say to people is you've just got to be extra specially careful. If you are unsure as to whether there is a pool of water on the floor in front of you, maybe take some kind of assistance, a stick or something, and just move it gently around. And I think you will know then if there is a water or a snake or whatever it might be. Otherwise, I think we're going to have to wait for Catherine. But coping strategies don't work for everybody, I have to say, but they do work for some people. And there are all sorts of things. You kind of have to, now this is where you can tell I'm not a doctor, you have to shunt your brain into another gear and switch off the cells. So people find clapping their hands, clicking their fingers, reaching out towards the hallucination. I appreciate if it's a snake or a tiger or something, that's probably not so easy. But if you can do that, anything that moves you really. Now, there's also a really good eye exercise invented by Dr. Dominic Fitch, which is on my website. It's also on my booklet, which I can send to people if they give me their address. Please, 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 can I just put in a little plea here? When you write to me, I love to get your emails, but you very often say, where can I go for help? But you forget to tell me where you are in the UK or in America or in Australia. If you will be really kind and tell me that, then I can point you very quickly. I think chatting to other people does help. And I know that the peer support that people find, and they make friends, local friends too, which is one of the reasons the Esme's Friends works so well. I think I possibly answered all that, Helen.
That's wonderful. Thank you so much, Judith. The next question is a question for Maria. Should there be more research in brain community, specifically in children and adults?
Sorry, I was muted. So I just said thank you, Helen. One of the things that we are doing is collecting information on ethnic backgrounds. And from the 13 patient case report of children, I can tell you that 7% were Asian, Pakistani in origin, 15% were Black African, and 38% were white British. But equally 38% had no ethnic background recorded. So yes, absolutely. I don't think we need to particularly target a certain group, but we certainly need to investigate anyone who is getting this, including all the kind of ethnic backgrounds, and then see after that if there are any trends that emerge. And with then that, we can then offer specific help to certain cohorts.
Fantastic, thank you, Maria. The next question is for Kat. Is the change in activity seen in brain activity seen in CBS relative to baseline?
Thanks, Helen. Yeah, so this kind of, what I need to maybe explain a little bit further is the way that we were actually measuring the brain activity, the functional brain activity here. So what we were doing was a comparison between when people were moving their eyes and when people were just staring straight ahead. So the staring straight ahead, or the rest condition in this case, was the baseline for this comparison. So that's what we were comparing to. So the level of activity that was going on in the visual part of the brain during that eye movement was a lot lower in CBS than the type of activity that was going on in that part of the brain in people who don't have CBS. One of the questions, however, that the protocol that we did use didn't really answer is how that relates to people's just general brain activity when they're not really doing anything. So that can sometimes be referred to as like the baseline activity for people's brains. So that's one of the things that we need to actually investigate further in future, is how that relates to that sort of baseline activity.
Fantastic, thanks, Kat. Next question for Dominic. Aside from atropine, which is a little bit more obvious, why do some of the other drugs make CBS worse?
So this goes back to the this thing about specific brain chemicals that act on our visual system. So it's acetylcholine is the one that we use in vision, and we know that anti-cholinergic drugs, so these are sort of anti-acetylcholine drugs, make visual hallucinations worse. Now, you all know, well, those of you that are using atropine will know that that's an anticholinergic, but so are these other drugs. So the ones, not all of them, but many of the drugs used to help urinary incontinence are in fact in themselves anticholinergics, and it's not really known that basically you're giving yourself this drug that is likely to make your hallucinations worse. The other one at the end, the the antidepressants, tricyclic antidepressants, one of their biggest side effects is an anticholinergic one. So that's why they cause it. The ones that I was going to say at the end, the gastric medication. So these are the ones that are implicated have an ozol at the end, so omeprazole or lansoprazole. So these are proton pump inhibitors. Now, there's a different story here. These are not anticholinergics, but there is some idea that they have some effect on retinal photoreceptors, and so we don't quite know why that causes the Charles Bonnet syndrome. And these are big studies looking at populations in eye clinics showing that, well, the people that had Charles Bonnet syndrome had a slightly higher risk of being on omeprazole and lansoprazole. So we don't really understand the mechanism for that. It's more an association. But certainly, if you want to look through your list of medications, don't worry so much about the side effect leaflet, because that will tell you everything. And that's, every drug will cause visual hallucinations if you have sort of very high levels and you're sort of being poisoned by it. But the ones that say anticholinergic side effects, those are the ones to look out for specifically, because that is what will increase your risk of the hallucinations.
Thank you so much, Dominic. And for Jane, do you teach the referral process for CBS?
Hello, thanks. Yes, we do. It depends upon, I think with the referral process with CBS, it will very much depend upon where you are and where you work, whether you are working within the hospital sector or the high street practice sector, or also different parts of the country, and very much depends upon what your local team is like. I mean, certainly we do discuss the appropriate signposting for advice and information to our patients from our clinic in Leicestershire to ESME's umbrella and appropriate similar associations. But certainly, as far as if you're within the high street sector, certainly I would sort of signpost to our local ECLO, eye clinic liaison officer or rehabilitation team, to also potentially pick up to discussing this on a one-to-one basis, and potentially put in also in contact with not just ESME's umbrella, but other maybe local groups that are discussing CBS. So yes, that's very much all part of it. It will very much depend upon where you're working within the sector and obviously what part of the country as well.
Great, thanks, Jane. Judith, I've got a couple of people asking about your ESME's rooms. Could you just give a bit more detail on those?
Yes, so before COVID-19 came along and locked us all down, local low vision charities were hosting ESME room support groups. And these were groups where people with Charles Bonnet syndrome gathered together over a cup of tea or coffee or even a glass of wine and exchanged their own experience of CBS, how it affected them, and if they had any coping strategies, because everyone is different. They exchanged those too. And they made friends, which was one of the really important things. So when Mike Bailey said, can we swap this now to a telephone chat service, because we obviously can't meet, and who knows when we'll be able to meet again, I thought it was a brilliant idea. And one of the things that has definitely come out of the ESME's Friends telephone groups is the friendships, because people meet, they know that the person they're talking to also has the condition, so they can call each other at other times as well and give each other that really important reassurance, A, that they're not alone, and B, that these hallucinations are not real. And I know that some doctors will say, yes, well, we know they're not real, why are they making such a fuss? But they're not making a fuss, because I think what I would love to see is some of the clinicians who are not as good as the ones we've heard today, who are very dismissive of it, just try and live with it for a day. So I think the point of the ESME rooms in the first place was just to give comfort, and the ESME's Friends telephone groups are doing the same. So if you need one, if you know of someone who wants one, then just contact me and I can put you in touch. And if there isn't one in your local area, you can nag your local low vision charity, or you can join another, because they're always open and very happy to help out.
Fantastic, thank you, Judith. So I now have a general question, so if one of the speakers could pick this up for me. Is there any effect of food or diet on CBS?
Can I just say something? So during lockdown, people did talk to me about using ginger. And I think I did mention it to Dominic, who said to me, well, ginger does have medicinal properties, so it's worth a try. I have spoken to a few people who have told me that eating, well, I think eating crystallized ginger, it has to be real ginger, helps them. Now, I have no idea whether it does or it doesn't. There's not been a study on it, but who cares if it's psychosomatic or not? If it works for them, that's all that's important. So that's the only thing I know about.
Can I just say something? So I think it's a very individual thing. I did have one gentleman who was very adamant that omega-3 supplements helped him. And in fact, we did a study on him and showed that the blood flow to his brain did improve on the omega-3, and his hallucinations got a bit better. But I suspect that those are unique things to individuals. So I don't think there's any blanket sort of nutritional things that we can say that would work. But obviously, you know, general healthy eating is always a positive thing. And whether it's going to have a specific benefit in Charles Bonnet syndrome, I don't know, but I would certainly encourage that.
Fantastic, thanks so much. If people are born blind, can they have CBS?
So I better take this one, Helen. So I think from what we're seeing from at least the case series, we can't absolutely say no to that. As I mentioned, a few of the children lost their vision within the first year or so of life. And some children were born with congenital birth eye defects, meaning their vision was very, very, very poor at birth, but they still developed CBS. So I think we need to do a lot more research into that. I would like to say no, that they couldn't, but I can't be 100% certain on that. And I'll maybe ask Dominic what his thoughts are. I suppose, I mean, it also depends, for example, on the conditions. So I would just say if you're born with something called anophthalmia, i.e. you have no actual eye formed, then potentially, you know, you don't even have an optic nerve and no stimulation to the brain and no pathway whatsoever, then maybe not. But with other conditions where there is some sort of connection between the eye and brain, then there is potential. But I'll pass over to Dominic.
So it actually is a question we get asked every time. We should have a pre-prepared answer for this one. But so it's a fascinating, it's got philosophical implications, a very important question. All I can say, just to add to what Maria was saying, so sometimes people that are born blind, it's difficult to have a shared language as to what visual experiences are like. So that's one issue. If they were to have hallucinations, how would they describe it? But I'm aware of one case who was not necessarily born blind, but certainly went blind within the first few weeks. They had a stroke in their later years, in their 60s, in the occipital cortex, and they had the typical patterns of Charles Bonnet syndrome that any patient would get. So that must say something about the fact that their visual cortex had evolved in a sort of normal way, at least part of it, even though it had never really been exposed to light at all. So my hunch would be, that probably you can get Charles Bonnet syndrome hallucinations if you're born blind, but the way you can discuss them and describe them may be slightly different to someone that has at least had some vision that they can remember, or at least that's helped shape the way that their visual cortex has evolved.
Helen, can I just add something as well? So only because I saw an 11-month or 10-month-old baby this week. Actually, no, today's Monday, last week. And so there is a phenomenon when you lose your vision very early on after birth, where little kiddies press their eyeballs with their fingers. It's called digital eye poking. And they're almost pressing their eyeballs to stimulate some sort of light activity. So it's not light, it's the pressing, the pressure on the cells that is causing some sort of discharge and signals. And so as Dominic says, I think that it's that perception that we're just not sure what exactly is it that they're experiencing. But for example, those children who are blind and doing that are certainly doing it to get some sort of it's not a visual response, but some sort of activity from their retina. So it's an area that needs a lot more investigation.
Thanks, Maria and Dominic. That's fantastic. I have a couple on this. Can people with nystagmus be affected by CBS?
I guess Maria can answer that as well. But so from my point of view, yes, they can. And there's some very famous cases where the direction of the hallucination movement was linked to the eye movement. So there's some cooperation between signals coming from the eye movement with what you're actually seeing. So the simple answer is yes, you can have hallucinations with nystagmus. Maria, anything you want to add to that one?
Yeah, and also just to say that nystagmus is often a symptom of a number of other conditions. So it's can be found in isolation. So you've got idiopathic nystagmus, but It's often found with, for example, aniridia and various other kind of albinism, so other conditions. And 100% absolutely, you can get Charles Bonnet syndrome where you have features of nystagmus.
Thank you both. And I think this is the final question now, and it's around medications and what's happening and whether there are likely to be anything soon to treat those with CBS.
Well, I think so. We have to understand the mechanism before we come up with the treatment. So I think that there are no clinical trials planned at the moment for specific medications. I mean, I'd love, if we had funding, there'd be hundreds of trials we'd want to do, but no specific ones at the moment. I think the next big thing is CAT's stuff, this electrical stimulation, because that actually focuses the bit of the brain that's causing the problem, rather than a medication which of course goes everywhere and you know, it's got much more wider effects. But so the simple answer is there's no specific new ones, but when we know the mechanism better, we will be able to select the best options. And then maybe that would be the time to do a clinical trial. I did announce last year that we want to do a cannabidiol one, but then of course COVID has come along. But so that's a possibility. If we can get funding, one of these cannabis related medications that seem to help hallucinations in other conditions, that would be a good thing to try as a next one, I suppose.
Yes, just if I could add to that as well, with our trial that we did in Newcastle, obviously the trial that we did with the non-invasive brain stimulation, it gave us some really interesting results, and it definitely gave us more of a boost to being able to pursue that sort of treatment further. So while we're still in the very early stages with brain stimulation, it's definitely something that seems to be worth pursuing in Charles Bonnet. And I think that one of the things that's most attractive about that is the fact that, as Dominic says, we can actually target the areas of the brain that are causing issues or producing these hallucinations to begin with. So it's not so much like a lot of the drugs which affect the whole brain and can also cause quite a lot of side effects. So that's definitely something to watch, and we're hoping that we'll be able to develop that further in future.
Wonderful, thanks so much. Can I just take this opportunity again to thank all of our speakers? They've been absolutely brilliant today. And also to urge you to take a look at the poll and fill out the feedback form. Thank you very much. I'm just going to hand back to Judith now.
Thanks, Helen. Thank you to everyone today for speaking. It's been absolutely marvellous. It could not be a better 5th birthday for Esme's Umbrella. 300 years since the birth of Charles Bonnet. This year is 2020, Year of Vision. Hasn't quite turned out the way we had hoped. But I think for the Charles Bonnet syndrome community, it is wonderful now to have everybody here today listening. And please take everything we've said, take it out into the community, educate others. And if there's anything I can do to help you, look on my website and contact me. Thank you all so much, and goodbye.